We get started. Good morning, everyone, and welcome back to our Grand Round series. We had a pause for the AAO last week, which sounds like it was a great meeting. Today, we return with one of our very own, Dr. John Lloyd, who many of you already know. Dr. Lloyd was the program director up until about a year and a half ago when he passed the baton to me, and he did a fantastic job, as all of you know, with our residency program and led us through a very successful decade with great graduates and a very successful review. So he's left the program in great hands. For those who don't know, John Lloyd has an interest in refractive surgery, both corneal-based, so LASIK and PRK, as well as IOL-based. And he's a very sharp mind in the refractive area space. So that's his interest. But his real interests are in things like sci-fi and Comic-Con and figurines. So I've seen the talent that this man has. It's not just in microsurgery, but it's in painting micro figurines with some very high level of detail. So if you ever get the chance, strike up a conversation with John about his real passions, of which refractive surgery is just one. I look forward to his talk this morning. I think he's got some new information and new data to share with us. So I look forward to that. So John, the stage is yours. Thank you for making the time for us this morning.
Thanks, Deep. I'm out of the closet now with my hobbies. So anyway, yes, anybody who cares to learn more about them, feel free to join me. But today we're going to talk about some refractive surgery, just some interesting information, some approaches to certain things. And then Safwan's going to surprise you with something that I'd never seen before. So Kirill, why don't you take it away with your first couple of informative cases?
Sounds like a Safwan thing to do.
Yeah. Thanks so much, Dr. Lloyd and Dr. Rai. So my talk is about optics. What is it good for? And just on the topic of sci-fi, I do think refractive surgery is very sci-fi at times. I want
to say, Kirill, it's the best title I've seen yet. What is it good for?
So we're going to start off with a case, and just to get everyone thinking about some of the issues we're going to talk about. So say you have a patient, 60-year-old female. She's had a history of LASIK surgery for +2 diopters of hyperopia, and she really, really values her spectacle independence. And however, she's now developed some mild cataract and a hyperopic shift, and her current refraction is, hyperopic with decreased uncorrected uncorrected distance visual acuity. You're looking at her orb scan here, and you can see that there is quite significant steepening of the central cornea, consistent with a prior hyperopic optics. So hyperopic LASIK. So what would you do? Let's think of, and there's no need to do a poll here. Just think about some of the options you would consider. So maybe an extended depth of focus lens, an extended depth of focus monovision. Maybe this is an impossible problem to solve and just use the OHIP lens. Maybe she can still consider the panoptics here and gain a measure of spectacle independence. So we have about 5 seconds.
While you're thinking about that, you could mention, Kirill, that it is possible to go back and do a LASIK enhancement. But as we've discovered, hyperopic LASIK just doesn't work as well as we would like. Its effects tend to wane sometimes faster than we like. And this is a person who's already 60. They already have some early lens changes. And even if you enhance them, you're only going to improve their distance vision, which frankly isn't even that bad to begin with. And this person would like to read.
Thank you, Dr. Lloyd. Exactly. So before we think about a possible solution to this case, we're just going to go back and think about some basic optics concepts. So we're going to think about spherical aberration and how it relates to the human eye. So spherical aberration is a fourth order ocular aberration. So here on the left, top left, you see both the paraxial rays and the peripheral rays are focused at the same point. So this is a neutral or aspheric lens. However, the bottom two examples are examples of either negative or positive spherical aberration, where in negative spherical aberration, the peripheral rays are focused behind the paraxial rays, and in the in the example of positive spherical aberration, the peripheral rays are focused in front of the paraxial rays, and so you get a bit of what's called here potentially myopic defocus. So now in the normal eye, the cornea has positive spherical aberration, so a little bit more of a picture, whereas the lens has a bit of negative spherical aberration, and the two, while they kind of counteract each other, they do not end up in this position. There's still a little bit of positive spherical aberration in the normal eye, which is also responsible for concepts like night myopia, when your pupil enlarges and is able to let more of the peripheral light rays through. And so most aspheric IOLs actually don't necessarily focus light, in this way, in a neutral or aspheric way. They actually have negative spherical aberration to try and counteract some of the positive spherical aberration of the cornea. So how does spherical aberration affect image quality? So here you have a series of images generated by a point source of light, and what you're basically seeing is that at every point it will generate halos around this point source of light. So this unfortunately decreases contrast and image quality. So here on the right, you're seeing what an image might look like when in a theoretical system without any spherical aberration, and a system with a little bit of spherical aberration. So here on the top row, you're seeing, at distance, you have a perfectly sharp image, perfect contrast, but then it devolves into a blob as soon as you're like around 1.5 diopters or so. Whereas with some spherical aberration, even though the image quality is degraded, you can still kind of make out what's going on. So you have an increase in the depth of focus, but you have a decrease in contrast. So
now, Kirill, if you go back to that for 1 second, I'll just point out that I think the reason they probably picked that 0.28 as a comparison is that is the average spherical aberration of the cornea. So this is representative for something that we might do in practice.
That's right.
Or what our patients experience.
That's right, exactly. So truly, if you were to put a truly aspheric IOL in to replace our lens, and this would probably would end up with. So
actually, Kirill, this is probably also the reason that when we put the OHIP lens in patients, which actually has a little bit more positive spherical aberration, it's why these patients sometimes tell all their friends, hey, look, I can actually read something, and you had to pay all that money you can't even see.
Makes sense, because it would yeah, that's true. So how does a refractive procedure such as excimer ablation of PRK or LASIK, how does it affect spherical aberration? So if we're starting with a cornea, and normal human cornea has a bit of a prolate shape, meaning it's is a bit steeper in the center and flatter in the periphery. And overall, even despite the shape, it has a bit of positive spherical aberration, as we discussed. So let's say you do a myopic correction. So you're going to flatten the center. So the central cornea becomes flatter, becomes more oblate, and that induces more positive spherical aberration. Alternatively, a hyperopic correction, you're actually working at kind of the paracentral kind of area here that steepens the central cornea. So the central cornea is steeper, it becomes more prolate and induces negative spherical aberration. So using these concepts, now how can we apply them to this case? Person has had a history of hyperopic LASIK, and which has induced some negative spherical aberration. What can we do to try and really help her? So as mentioned, so the question is really, can you use a multifocal IOL like the PanOptix in a patient with a prior history of hyperopic LASIK? So hyperopic LASIK preferentially ablates the mid-peripheral cornea, steepens the central cornea, has a fairly large treatment zone, larger than myopic LASIK, and good predictability kind of with up to about 4 diopters. But as Dr. Lloyd mentioned, there's also quite a bit of regression that can happen. And important for our case, it induces negative spherical aberration, plus also other higher order aberrations. So most aspheric multifocal IOLs actually induce some negative spherical aberration. So the PanOptix itself is about minus 0.10 microns. to account for the positive corneal spherical aberration. Now, hyperopic LASIK will induce negative spherical aberration. So now you're going to be adding more negative spherical aberration to a cornea that's now could have a bit of negative spherical aberration itself. So in contrast, myopic LASIK induces positive spherical aberration. So how can we put this together? What can be done to minimize sort of the visual aberration due to spherical aberration produced by this patient's cornea? So the plan here would be actually to target myopia with then a post-op myopic enhancement. So you're going to put in a negative spherical aberration IOL, and then you're going to do a myopic enhancement, which will add some positive spherical aberration with the intent of minimizing these optical aberrations that the patient may have. And so here's what we did. Here's the details on the implants. So the initial implant for the right eye would result in an uncorrected distant visual acuity of 2150 with a refraction of about -2. And similarly for the left eye, you will get an uncorrected distant visual acuity of 2080 with a manifest refraction of -1.5. And then she gets a laser treatment about 3 weeks later and actually has an excellent result. So uncorrected distance visual acuity is 20/15 in the right and 20/20 in the left. And she's actually very satisfied, able to do all of her tests and remain spectacle-free most of the day. So similarly, in the same vein, this is a different case. This is a 60-year-old male. He's had LASIK previously for significant degree of hyperopia that's regressed over time to plus 1.5 diopters of hyperopia, and then he had another LASIK retreatment, and now he presents with hyperopic shift again. And again, we're also dealing with someone with whose lens is presbyopic as well. So how can we account for this? Again, here we aim to target -2.5 myopia with post-op myopic enhancement, essentially the same concept there. And again, this patient also, immediately after surgery, the uncorrected distance visual acuity is 2200 in the right, 2150 in the left, with a myopic refraction as predicted. And after a laser enhancement, again, uncorrected distance visual acuity is 2020, and this patient is happy, spectacle independent. So these two cases are meant to illustrate how can you use concepts like like spherical aberration and how laser treatments and how IOLs affect this to try and give people with a history of prior hyperopic LASIK a good visual outcome and allow them to be spectacle independent for the vast majority of the time. So now we're going to talk about a case of a refractive surprise. So we have a
Kirill, before we get there, just because I think that this is going to be a different case now. Just a couple questions here, maybe for John. Is how are you selecting the original, like the post IOL refraction when you're targeting -2, 2.5?
Yeah, so actually, I just wanted to put these cases out because this is an evolving thing, and I'm not presenting this saying that this is what you must do or this is what you have to do. Or even that we know for sure this is the best way to do it. But it came up at one of our meetings. It was actually one of my colleagues who doesn't even do cataract surgery that suggested it. And the idea is that patients who have had hyperopic LASIK not just have increased negative spherical aberration, but they just have, quite aberrated corneas in general. And these multifocal lenses were designed for patients that had, hopefully normal corneas. So he said, well, why don't we just, essentially reverse what they had done in the first place? And so the concept was to maybe go back and look at what their initial treatment was and essentially aim for a myopic target that's roughly equal to what their hyperopic treatment was before. And that was the idea. So this is just sort of an idea in evolution. And I just wanted to put it out there for, you and the next generation of IOL surgeons to think about. I don't know for sure it's the right answer. It has worked in a handful of cases that I of which Carell presented several, and it's an interesting idea.
Thank you.
All right. So let's move on to something different, but still very relevant to patients that have had prior history of LASIK correction. So here we have a 31-year-old female commercial scuba diver. She's had, she tells us she's had history of LASIK in both eyes 10 years ago. First treatment and enhancement in the right eye 7 years ago. Unfortunately, the LASIK center that she went to is bankrupt, defunct. You don't have any actual data from there. So you kind of have to go for patient history. Now she comes to you, she complains of glare, halos, and blurry vision in the right eye. Current refractions about in the right eye is plus 0.5 diopters with a best corrected visual acuity of 20/40. The left eye is plano and with an excellent uncorrected distance visual acuity. On examination, though, you notice that she actually has visually significant cataract, which explains her symptoms and decreased visual acuity. So our initial plan was to use, okay, fine, we used the Barrett-Truquet formula with LASIK correction. We put in a plus 24.5 lens, and she tells you she's happy with her reading vision, but dissatisfied with her distance vision. So her uncorrected distance vision is 2100, and the manifest refraction essentially is minus 3 diopters, plus 0.5 diopters of SIL. Best corrected visual acuity maybe gets to like 20-25 plus or so. And so we're kind of scratching our head. This is a person that is a commercial scuba diver. She really would prefer not to use glasses as it would interfere with her work. So what can we potentially do here? And maybe why? And before answering that question is, why did this patient have a myopic surprise? And so I have a few options here for you to think about. So a macular staphyloма was missed in examination, maybe. There was no need to use a correction for LASIK because the patient stated that her pre-op refraction was small. A resident did the surgery, they ran the rhexis, and now the IOL is displaced forward. A large amount of viscoelastic is trapped behind the lens, or the type of correction for LASIK was incorrectly entered into the formula. But think about these. We're going to go through them one by one. So actually, macular staphylomas should cause a hyperopic surprise. That's the first portion is incorrect. B is incorrect just by concept. You do need to correct for prior LASIK, and we'll talk about why shortly. C is incorrect because this resident never runs the rhexis. And D, well, it's possible. This is the capsular block syndrome that can induce some curve to the posterior surface, the capsule there. But we confirmed it wasn't the case here. So we're kind of left thinking about E. Is E possible? So let's think about the type of correction that you need to be thinking about for prior refractive surgery. And it actually matters. So if we think about how IOL power is corrected just at a high level, it's essentially a function of vergence, i.e. that we want to achieve, and the effective lens position. Now, the effective lens position is what matters here. It's partially inferred from corneal curvature, in other words, K value. So, for example, for someone that's had myopic LASIK, here you're seeing the central cornea is flat, right? So the flatter Ks might suggest a smaller AC depth, and the central K may be overestimated. So then that results in underestimated IOL power and hyperopic surprise, which if you don't correct for, you're going to run into this issue. And similarly, if you're looking at someone who's had hyperopic correction before and the central cornea is steeper, now steeper Ks may suggest a higher AC depth, and central K may be underestimated. And so then you might overestimate your IOL power, and suddenly you'll get a myopic surprise. So let's look at our patient. This is the UofT scan for our patient. Does this look similar at all to one of these two pictures? Are we dealing with a myopic correction or a hyperopic correction? So clearly
So
here,
Carl, can we just go back to that
Yeah.
last slide, just because this is a very confusing topic, so just for the sake of our
Mm.
residents, 'cause I know this comes up on exams. Just with the myopic correction, the flatter case suggests a smaller AC depth. So it just like, you know, it gives the formulas the idea that this is perhaps a hyperopic eye. It's a small eye because the Ks are flat, and therefore the formula assumes the effective lens position is a bit more anterior because it's thinking it's a hyperopic eye, and therefore it calls for a lower power IOL, and that gives you the hyperopic surprise. And the opposite is true with the hyperopic correction. When you have steep Ks, the formula thinks that this is a myopic or a longer eye, and the IOL is going to sit more posteriorly. And when it sits more posteriorly, you need a higher power IOL, and therefore you falsely selected a higher power IOL, resulting in myopic surprise. So I hope that makes sense, because I know this is a confusing topic, but you presented it perfectly here.
I'm happy to send these slides out to the group as well. So if we look at this here, at our patient's data here, so here we have, you know, fairly regular kind of Ks, not much astigmatism, and you know, nothing that suggests maybe out of the ordinary at first glance. But actually, when we look more carefully here, we actually have some steepening of the central cornea. So we actually are dealing with a hyperopic or history of hyperopic LASIK. And so when we look at our IOL master, actually this was done with a Barrett-Trouquet formula, and it was done in the myopic mode. And so the lens that it called for was a 24.5 diopter, that 24.5 diopter lens that unfortunately caused a significant myopic surprise. So what do you do now?
Kirill, can we go back for 1 second?
Sure.
I'm going to ask the PGY5s in the room a question. So not Kirill or Safwan, but somebody else in the room. There's another clue on this IOL master that perhaps this patient had hyperopic LASIK. Is there a PGY5 or maybe a PGY4 who would want to answer that?
Go ahead. You're good. They have fairly flat corneas now.
Well, the cornea is hard because the Ks are pretty average, right? Like the spherical equivalent of the Ks is 44. So if this person had previous LASIK, you have no idea that they start off flat and they got steeper, they start off steep and got flatter. It's hard to know, but there is another clue on here.
AC depth.
AC depth, what else?
Axial length.
The axial length, yeah, the axial length.
The
right?
axial
Like,
length.
it is a shorter eye here, and you know, it's not impossible, but it's unlikely that someone with a 22 millimeter eye is a previous myope, or 22.75. So you can look at that as well as a clue, because the case here, I agree, she probably had a very small treatment, so it's difficult to know. Sorry. Pearl.
No, thanks so much. Thank you for pointing that out. And so it has the importance of really looking carefully at the IOL master printout. So, okay, now you're sitting with this patient in front of you. You just did the surgery. What do you do now? So glasses, contact lens. Let's give her another enhancement, number 3. Or do we think about an IOL exchange? So the first 2 options are fortunately aren't applicable to patient desires. Spectacle independence, we tried a contact lens trial, she did not tolerate it. What about C? So here we have a photo here, and maybe again, I can ask maybe a PGY4 or a PGY5 to tell me what this photo might show, and what this photo might suggest, if this photo might help us pick between these 2 options. So really anyone can just shout out the answer.
Epithelial end growth.
That's right, epithelial ingrowth. So this probably suggests we should probably not, and what I'm putting out here is this is what they're trying to show. So we're probably not going to be doing another LASIK enhancement. So we're left with an IOL exchange. So what will we do? So we'll use the Barrett RX formula, not the Barrett-Trouquet at this point. And this is maybe not something a lot of people are aware of, but if you just Google it, you will find this ACRS calculator. You insert the data for the surgery that you did. as well as your K data and so on, and then it will calculate which lens you should use. In this case, it was replaced with, I believe, a 21.5 diopter lens, and she had again excellent outcome after this, with 20/20 vision in both eyes at distance, and was happy. So just to bring this all back together, and so in summary, patients with a previous history of hyperopic refractive surgery who are still valuing spectacle independence and seeking a multifocal IOL, targeting myopia with a post-op enhancement may actually help reduce some of these may help account for the spherical aberration and improve refractive outcomes. It's very critical also to properly correct for history of prior refractive surgery to prevent yourself from getting a refractive surprise after cataract surgery. And the Barrett RX formula, as mentioned on the previous slide, is very, very useful for planning an IOL exchange should you not heed the advice of point number 2. So
well, I'm just going to move it along so we can get through our things. I'll just mention, so this young lady actually did do a contact lens trial for a while. Turned out she liked a little bit of residual myopia. I think I put in a lens that left her -1 or something, and she's very happy with it. It seems fairly obvious when you present it what this is, but the concept here is that you do have to think about it. Who would have thought that some 21-year-old girl who had a small correction, would have actually had a correction of 150 or some nominal sum? You would think that wouldn't even need LASIK. So it's a bit of an interesting case. And her EI, her epithelial ingrowth, was relatively small and didn't need any treatment. But if you went and did a LASIK enhancement and stirred it up, you'd be likely to deal with much more troublesome ingrowth afterwards. So an IOL exchange can be quite accurate after you know your results from your first surgery, because you can use formulas to really pretty much figure out exactly what you want to get. So if you want to stop your share, Kirill, I'll put mine up now. Okay, so I'm just going to scoot through this expeditiously, so we have time for Safwan's case as well. So, questions? Why are my slides not advancing here? There we go. Okay. So this is an old slide that I keep throwing up, just showing that I've previously given talks where I show you that roughly 4% of the Canadian population has had LASIK, and that doesn't sound like much, except you realize that all those patients are in that 20 to 40 age group, and they're coming for you. So this is directed to the next generation, all you residents sitting out there, they're coming. That's about 1 in 6 patients in that demographic, and we've now had LASIK for 25 years, so they're coming. They're coming through. So you need to worry about this stuff in your IOL exchange, even if you don't do any LASIK. And Kirill covered this very nicely, the spherical aberration. So just to show a graphic here, if you flatten the cornea, you're going to move the central rays backwards and causing an increase in positive spherical aberration after myopic LASIK. And if you steepen the central cornea, you're going to move those central rays forwards, increasing the negative spherical aberration. And in terms of Kirill's first case, the hyperopic LASIK patients wanting multifocal IOLs, it is worth noting that, I think it's cut off here on my screen, but even with our current formulas, we only get within half a diopter, maybe 60% of the time. So since we're going to be enhancing 40% of the patients anyway, maybe it's not that unreasonable to plan to enhance 100% of them and improve their corneal curvature to make the PanOptix lens or similar multifocal lenses work better. Kirill has covered this quite nicely, but I have a slide reminding you that there are 3 sources of error when we do post-LASIK patients. One is that we are changing the ratio of the front to the back of the cornea so that our formulas, which use this formula to predict the power of the cornea as a sum, it's actually the sum of the front and the back, that ratio breaks down and is no longer correct. These are sources of error in myopic lesions, but every one of these errors works in the opposite direction with hyperopic LASIK. Keratometry errors, the machines do not measure the very central point of the cornea, although with our latest generation machines, they're getting much smaller. So the LensStar and the OwlMaster 700 do measure much more into the center of the cornea, so this is probably less of a problem now. And then Amandeep brought up the point about ELP. Many of the formulas use the corneal curvature to predict if the anterior chamber depth / effective lens position is going to be more or less anterior. Newer formulas don't rely upon the Ks, but rather actually measure it. All right, so what I wanted to present today very briefly is a study that's coming out in JRS within the next few months, angle kappa and multifocal IOL implantation. Much has been spoken about this. A lot is not known. I want to present our data and our study. So, does angle kappa influence multifocal IOL outcomes? So this is a picture from your AAO book showing the various axes of the eye, and I'm going to go into this more detail in a moment. So we use at our refractive center a machine called the OrbScan 2Z, and on a simple level, this machine is a topographer that measures the corneal topography, and it centers the image on the corneal vertex, which is a good approximation of the visual axis. And then the pupil center, measured perpendicular to the lens, is projected back onto the cornea. So here's an idea of how this would work. If you look at this, you can see that the patient is fixating on the ring target, and you can see their corneal apex, which approximate their visual axis, and then the red lines show the center of the pupil. The difference between these two things is an approximation of angle kappa. Now, there's more to it than just that. But here's some pictures to show you. So ignore this little dot. If you look here, you can see the X represents the corneal vertex. There's a little smaller dot representing the pupil center. And then there's the K reading, which is the projection of the optical center onto the cornea. In this case, all the dots are very close together. In this case, you can see that the K is significantly away from the other two, the X and the dot. This little red one here is the thinnest spot on the cornea, so ignore that. Here's another one where all of them are separated. The corneal apex, you can see the pupil center is way over, and the kappa is even further over. It is worth noting that this study was done with the OrbScan 2Z, and each machine does have its own proprietary way of measuring angle kappa. So if you go to Uday Devgan's nice website, it shows you some of these issues about how these various points may or may not be aligned. And if they're not, what do we do about it? So this slide has been exaggerated to show how the OrbScan 2 measures the so-called kappa intercept. The patient's visual axis is where they are fixating the topography rings. The pupil center is projected at a 90-degree angle over to the cornea, and that is recorded by the machine as the kappa intercept. So what do we do in a patient if the kappa is not 0? Obviously, if it's 0, we're going to try to put the lens right in the center. But if it's not, what do we do? Do we center the lens on the pupil center, or do we center the lens on the presumed rough visual axis of the patient? Obviously, the lens may perform less well if the light is not coming in through where it was designed to come through. In addition, if we do center the lens on the patient's visual axis, the pupil may actually limit the light to some of the rings, and it may allow light to pass through the lens in an area where there are no rings, causing asymmetrical diffractive patterns and degradation in image quality. This is a theoretical paper, which is actually, interestingly, not done with a diffractive lens, but rather a segmented bifocal. But in their study, they showed that if you centered the lens on the patient's visual axis, the impact of angle kappa was the least. And in fact, it had very little impact on near, intermediate, and even distance vision. There has been conflicting results in the literature. These are all the studies to date looking at angle kappa, and they conflict with some studies suggesting a negative impact on outcomes and some studies showing no influence. Interesting enough, this study by Sandoval, which comes out of, I believe it's Olson Center in Utah, with the Panoptix lens, 56 patient, showed that some patients' angle kappa even changes after multifocal IOL implantation, that it changes after they have the lens. If you look at these studies, however, only 2 of them even go into 3 digits on their number of patients. So in our study, we looked at the angle kappa measured by the Orscan 2Z on our patient visual, refractive, and satisfaction outcomes. All patients over approximately a 3-year period having trifocal IOLs. We did not allow angle kappa, pupil size, or higher order aberrations to factor into the candidacy. And the IOL centration was actually left to surgeon discretion, with about half of the surgeons attempting to align the IOL with the patient's visual axis. So these are real world outcomes, the way anybody would do the surgery. These are the 2 lenses that were used. This is how the kappa intercept was calculated using the vertical and the horizontal measurements, using Pythagorean theorem to get a distance, a linear distance. Here are the results. So we didn't mess around. This is not 50 eyes. This is not 100 eyes. This is 26,470 eyes. And you can see that the average angle kappa was slightly temporal to the visual axis, which we would expect. You know, if you shine your light at the patient, most patients appear to have their first Purkinje reflex slightly nasal to the pupil center. The average kappa was about 0.64, with 72% of eyes having more than 0.5 millimeter, 12% having more than 1 millimeter. There was no clinical or predictable relationship between the preoperative angle kappa and the postoperative sphere and cylinder. You can see it's a straight line. You can see there is variation on the outcomes. Post-LASIK patients were also included in this data set. You can see there is a wide range on the outcomes, but when you fit a line to it, it's straight. Same here on spherical equivalent and something called the defocus equivalent, which is when you take the absolute value of the cylinder, because we all know that a result of -1 + 2 cylinder is not the same as having a spherical equivalent of truly 0, or at least a result of plano. So defocus equivalent takes into consideration the effect of mixed cylinder prescriptions. There was also no clinically meaningful or predictive relationship between preoperative angle kappa and monocular uncorrected distance visual acuity. Interestingly, we have satisfaction surveys showing a straight line for near vision, intermediate vision, and a very slight reduction in the satisfaction for distance vision, but this is over 5,000 eyes. This is how many patients we have survey results from. The R is still very close to 0. And finally, despite that small negative trend, the likelihood of recommending this to friends and relatives was also a flat line. There was a slight relationship between higher angle kappas and more positive hyperopic preoperative sphere, which is a known relationship, and IOL calculus may be somewhat less accurate in short eyes. So the conclusions from this are the following. At least for the OrbScan 2, an angle kappa threshold of 0.5 is too conservative, and we should reconsider that because it would have excluded 2/3 of the eyes in our study. Greater than 16,000 eyes had an angle kappa greater than this, and it had no impact on our outcomes. By the same token, angle kappa is not the holy grail for determining who will and who won't do well with a trifocal IOL. This is both a pro and a con. We all know that there are unhappy multifocal IOL patients, and we all know that these patients cause us a great deal of grief. We might have to do an IOL exchange. They may be unhappy. And unfortunately, angle kappa may not be the way to fully know who will or won't do well with these lenses. And then finally, we did not look at things like higher order aberrations or postoperative contrast sensitivity, but we did look at patient satisfaction, which I think is a good surrogate marker of these things. So there are the final conclusions, and it's an interesting study with a very large series of data showing that this relationship, unfortunately, is not going to give you a way to fully know who will or who won't do well with trifocal IOLs. Thanks to my colleagues, Abby Wallerstein and Matthew Gauvin, the engineer who put all this data together. Thank you.
That's fascinating. I think that's because people have been trying to look at that topic for a very long time. And I think many were starting to swing in that direction, that angle, because we've seen patients with small angle kappa who are unsatisfied, and patients with large angle kappa who are surprisingly happy with a trifocal IOL. And I think you've perhaps put that issue to bed now. So thank you for doing that work.
I think it's interesting. I think that we probably have less control over where that IOL tends to center in the eye, even if we think we're trying to align it. And maybe we do align it, maybe we don't, or maybe it just, this relationship seems that it's not the holy grail for figuring out who will or won't be happy. And I've left enough time for Safwan to move on to his interesting case.
I think we'll wait for artificial intelligence to help us figure that one out. Who's going to be unhappy with which IOL? Safwan, the floor is yours.
All right. Good morning, everyone. My name is Safwan. I'm one of the PGY5s, and I'm be presenting an unusual case of iritis that was recently seen at one of the teaching hospitals. So our case today is for a 77-year-old gentleman who came to the emergency department actually with pain, decline of vision, photophobia in the right eye for 2 days. He has a past ocular history of microvascular sixth nerve palsy that was resolved already 3 months ago, normal MRI. And he has a past medical history of adenocarcinoma of the prostate, but this also in remission for the past couple of years. And his review of symptoms is unremarkable. So in clinic, he had an excellent visual acuity of 20/20 in each eye. His intraocular pressures were normal. And his anterior segment exam in the right eye was notable for 3+ white PCs, 2+ hyphema, and iris lesion temporal, as will be shown in the next slide. And the left eye was completely normal. The fundus exam was completely normal in both eyes. So here's the slit lamp photo of the right eye. And here I would like to ask one of the BGY2s maybe to describe the photo. Maybe I will pick Brian or Yusuf. They're there.
So we have a slit lamp photo of the right eye there. From the view here, it looks like the anterior chamber is a little hazy. And then as you can see on the iris temporally, there's like a large, like reddish bluish mass. Perfect.
So what would we do next? So we manage the anterior uveitis as every other case of anterior uveitis, topical steroid and cycloplegia. And the patient hyphema was managed conservatively. The IOP was normal. And the patient was referred to PMH ocular oncology for iris lesion NYD in the right eye. So here's the PMH workup. As Brian astutely alluded to, it's a large red to blue iris mass around like 4 millimeters in diameter, and maybe some overlying heme, and it's at the pupillary border. And here as well, the UBM scan, as we can see, this mass has both solid and cystic components. The depth is around like 2 millimeters, and most importantly is not invading the iris structure and stroma. So based on the information given and the pictures, what do you think the most likely diagnosis? Is it iris granuloma, iris melanoma, iris cavernous hemangioma, or iris mets, or AV malformation? I'll give 30 seconds for the audience to answer.
You know, Safwan, this is very fascinating for me because as the audience answers, I'll just share with you that I've had just in the last, I don't know, 2 or 3 weeks, a very similar case present. And I haven't seen something like this in practice previously. Mine was a young woman actually who developed it during pregnancy, but I'm curious to see where this goes. But I had a very similar presentation to yours just recently. I'll give you the results of your poll here.
All right, so it seems like we have a bit of a split between cavernous hemangioma and METs. But actually, this is a cavernous hemangioma of the iris. Iris mets usually present with more of hypopyon and intense AC reaction. You wouldn't see a mass collection. For the iris melanoma, usually you would see some more of a melanotic lesion. You would see a feeder vessel. It might be some destruction as well of the underlying structures in the UVM. An iris granuloma usually is much smaller than that, and it's multiple. So the team at PMH felt that this is actually consistent with iris cavernous hemangioma, which actually very rare. In our review of the literature, less than 30 cases have been actually confirmed yet. And it's usually clinical diagnosis and just aided by imaging. You don't need histopathological diagnosis to make the diagnosis of iris hemangioma. And these lesions are usually very asymptomatic until they bleed. And then the main concerns will become hyphema-related complications, as you know, uveitis, elevated IOP, and corneal edema and blood staining, or either angle issues, like the angle being shallow and obstructing the aqueous outflow. And although rare, it's important to mention that adult onset iris hemangioma can be associated with systemic hemangiomas, particularly CNS hemangiomas. So screening with brain MRIs should be considered. So how would you treat this lesion at this time? So as I alluded to, like these lesions are, it's actually very rare. So there is no randomized control trials or a treatment guidelines, but here's some of the treatment options that were described in the literature: observation, laser photocoagulation, brachytherapy, and surgical excision. So we'll go by the management options one by one. So observation might be considered if these lesions were asymptomatic and very small and not causing any issues, and if the patient elected to do so. Or if the lesion is not causing like frequent attacks of hyphema, uveitis, and elevated IOP. The second is laser photocoagulation. This actually treatment was adopted from the treatment of iris microhemangiomas, which is a much smaller lesion. Usually it's an office argon laser. It may be suitable for like smaller size lesions, and not as big as this one. And usually would require like 4 to 5 treatments. And again, there is risk of treatment failure and recurrence that the patient should be aware of. And brachytherapy, it's a low dose radiation. It's a definitive treatment. Usually it's only one treatment that the patient would need. But again, patients should be counseled about the side effect of radiation, which include cataract, glaucoma, optic neuropathy, and retinopathy. And finally, surgical iridectomy. And this is the only treatment modality that would actually yield histopathological diagnosis. So it certainly should be considered if there is any diagnostic uncertainty. But again, the side effect of taking out a large piece of the iris would be photophobia and cosmetic concerns, among others. So back to our patient, his anterior uveitis has responded to topical steroid, and hyphema has resolved spontaneously. His IOP remains stable. Actually, given the size of that lesion, the team at PMH felt probably radiation would be a good option here. However, given that it's the first episode and that's resolved spontaneously, resolved with topical treatment, the patient elected to observe at this time. And finally, I just would like to highlight, this is another case was treated at PMH, a similar case of iris hemangioma. And we're actually very fortunate in Toronto to have the expertise of the ocular oncology team at PMH, Dr. Prima and Dr. Antumari and the team. So this is an iris hemangioma that was treated with radiation. And here we see a nice resolution of this case. Dr. Prima actually have treated 2 to 3 of these lesions, and then they're publishing their results soon. With that, this concludes the presentation. Thank you so much. I would be happy to receive any questions.
There's a question for you, Safwan, in the audience. Is there any association with this and von Hippel-Lindau?
And not with this kind of hemangioma, and that's with the cavernous hemangioma. It's usually is not part of any systemic syndrome.
Okay. This is fascinating because just in the last couple of weeks, I've had the exact same thing walk in, and so really, really rare stuff, but we're very fortunate to have the ocular oncology service to help us out with these cases. So thanks for sharing that.
So one for that great presentation. Like you, Amandeep, I've gone through my entire clinical practice and never seen such a thing before. Initially, I assumed it was, some sort of MET or some sort of iris melanoma, which again, once it was worked up at PMH, obviously that was not the case. And then here we were in this situation. I had sort of hoped that as we presented the case, a clear treatment paradigm would emerge. But as Safwan has alluded to, there's minimal information in the literature as to what to do, and the experience at PMH has been helpful. This patient's lesion is quite enormous, and he's understandably not very keen to do anything because he's asymptomatic at the moment. But the size of this lesion, that big piece of big blood thing on it there, suggests that he's probably going to have recurrent episodes, but I guess we'll have to see. So he may yet come to brachytherapy as was recommended, but for now, we're going to monitor him.
No, I think that's such a cool case. I'm just going to show you, see if I can pull up, just for comparison. I don't know if you can see that, but I pulled up. This is the one that walked into my clinic just recently. Also presented with the spontaneous hyphema. And I think she actually presented internationally with the hyphema during the late stages of pregnancy, and so for her, she was symptomatic from the hyphema. I think it probably crossed her pupillary axis, so she must have had a large bleed. But once that settled, this was the remnant, so I quickly got her over to Princess Margaret as well. But fascinating that we've had a couple of these in the last little while.
Well, has she had her workup yet? Is it a hemangioma, cavernous hemangioma as well?
She has had the workup. I was just looking. I have it because I just saw her on October 13th. I do think she's actually seen Dr. Crema, but I don't have a report yet. So, but I did hear from the referring physician who sent the patient to me is a friend of the patient. So I do think it's a hemangioma as well, but I haven't received the formal report yet.
Dr. just a question. Is it is it a new lesion for the patient, or did you have like kappa hemangioma as a child, as a kid, and then this just being
Sorry,
grown?
Safwan, can you repeat the question?
So, for your patient, would this lesion like develop de novo, or she had the capillary hemangioma when she was a child, and then this is just a recurrence?
No known history of this. So on history, the first presentation of this was in the late stages of her pregnancy.
Yeah, and this patient, who is a new patient to our clinic, it's fascinating because his tumor is quite enormous, and he must have had an eye test at some point, over his lifetime. But we just don't know. It's just not been identified in him before. Did it rapidly increase in size and then bleed? It's not known.
Okay, well, thank you guys, John, Karel, Safwan. Thank you for your wonderful presentations. Katie Birch says it's a nice increase to the PMH case series. Absolutely. Thank you guys. The evaluation link is in the chat box. It's required for CME, and we will see you guys next week for grand rounds. I'll ask the residents to hang on for a little meeting afterwards, but thank you to everyone else for joining today. Thank you, John.